Tonight is going to be a little bit of philosophy and theology explaining Catholic Church teaching on end-of-life issues, and some beautiful images from the Middle Ages, which I'll get to later. And then Dr. Flanigan will come up and talk about he's also a Roman Catholic deacon, will come up and talk about his personal experience as both being a deacon and a medical doctor at the bedside of people who are dying. Beautiful stories about how this Catholic teaching can be implemented, if you will. And then next week, it'll be on end-of-life documents. So like living wills and powers of attorney and different things like this. I think they can hear me. I think this works. Yeah, this works, right? You can hear me back there? Okay, thanks. We'll talk about end-of-life documents and try to see what Catholic teaching says about how to fill those in. And we'll have a lawyer here who can help people fill those in. And then the third night is maybe the most important night. Well, first I'll talk a little bit in the third night about the Rhode Island bill that is trying to legalize physician-assisted suicide. I'll mention it briefly tonight, but I'll show you some of the content of it on the third night. And then we'll have Father Bob Bally and some Little Sisters of the Poor, who looks like they just walked in, to talk on the third night about maybe the most beautiful thing, which is how to actually care for people who are going through the dying process in a Catholic way. Okay, so that's what we're doing. And the idea is to, through a talk like this and through, practicing this, is to kind of gradually try to restore a Catholic ethos to Catholics and maybe the wider culture on this question of death and dying. It's one thing, and it's a very important thing, to go up to the State House and try to convince lawmakers to vote against the bill. But it's a more important thing to create, maybe for lack of a better word, a grassroots movement with people who have a deep understanding of a Catholic understanding of death and dying imbued in the culture. That would be maybe even more important. So, okay. So you can see the first slide there. So I'm going to start now, and this is going to be some sort of philosophical and theological explanation of Catholic teaching, kind of building the groundwork for what we're going through. So the first slide there, it's a picture of St. Joseph, the patron saint of a happy, good death, because that would be maybe the best place to die, with Jesus on one side and Mary on the other of you. And that's where he experienced his death. And I think the mouse isn't working. So this is a picture of Mother Teresa of Calcutta, and she said that if we have no peace, it is because we have forgotten that we belong to one another. And we all depend on each other. We all need each other. And we're all vulnerable. And God set it up that way because actually he's a trinity of persons. God is a trinity of persons, always living in communion. And so it's not only sick and dying people who are vulnerable and need each other, but we all depend on each other in myriads of ways. And we need to remember this. And Mother Teresa says that's the source of world peace, actually, to remember that we are dependent on each other. So in this question of a Catholic understanding of death and dying, we can start with a foundational question, and that is the sick or dying person placed at the center of attention, or is the sick or dying person abandoned, isolated, and ignored? Maybe in our culture, we generally speaking could say that we have a maybe death-averse culture, which I'll talk about more as we proceed. But let's remember this question in our minds, and later I'll come back to it. Is the sick or dying person placed at the center of attention, or is the sick or dying person abandoned, isolated, or ignored? That's a foundational question. So to start, basic distinction. Two ways people can die, or two causes, you could say, of death. One is a natural death, and one is death by killing. So a natural death would be when someone dies of old age, or illness, or organ failure, or disease, or injury, or an accident. Those are ways people die a natural death. And Death by killing is when one person kills another person or a person kills themselves. I know it's a very fundamental distinction, but that's the first step, this distinction. 2 different ways people can die, a natural death or by being killed. So briefly, I'm going to talk about this, as I said, on the third night, but there's a bill in Rhode Island, and maybe some of you are familiar with it, called the Lila Manfield Sapinsley Compassionate Care Act, which would make physician-assisted suicide or MAID legal in Rhode Island, and I'll define that in a minute. And that's the number of the bill. And what this bill, it's not legal, it's legal in about 9 states and Washington, D.C. right now, physician-assisted suicide. It's not legal in Rhode Island. Every year they bring up the bill again, and then it always gets tabled. So what it would do in a nutshell, and as I said, I'll speak about it more on the third night, it would make it legal for doctors to prescribe a lethal dose of medicine to some patients for the express purpose of enabling them to use it to kill themselves. That's what this bill wants to make legal, okay? So, all right. And I said that, okay. So now euthanasia and PAS means physician-assisted suicide, okay. So there's obviously the side of people who think it should be illegal and that it's immoral, and the side of people who think it's morally fine and should be legalized. So both sides agree that euthanasia and physician-assisted suicide are death by killing, so natural death or death by killing. They agree on that. Now, I want to just talk a little bit about some terms. So euthanasia actually comes from 2 Greek words. When you put them together, it means a good death. Unfortunately, ars moriendi is a good death. That word is now sort of co-opted to mean, euthanasia means when a doctor does the injecting of the overdose into the patient to kill them. That's euthanasia. That's how they use the word euthanasia. Physician-assisted suicide, the one that the Rhode Island bill wants to make legal, is when the doctor doesn't do the injecting of the overdose. The doctor writes a prescription for the patient to get, and that is a lethal dose of medication that the patient ingests themselves. And as I said, I'll explain the details of the bill later. So in Europe, when they legalize this, and believe it or not, Canada, they always legalize both of these. So Holland and Belgium and Canada and these places, euthanasia is legal. Doctors can kill patients, and physician-assisted suicide is legal. But in America, when we legalize it, it's always just physician-assisted suicide. We've never legaled euthanasia in America. And I've wondered about that. I need to look into it more myself. I suspect the reason is we're so addicted to suing each other in America that it's just too risky for doctors to do. So, and then the word killing. I just want to talk about the word killing. So sometimes I give this talk at places that aren't Catholic settings, like just to other places, and people a lot of times get mad at me when I use the word kill. And on the one hand, I guess I can understand it because the word kill is associated with the word murder. And many of the people who are participating in physician-assisted suicide where it's legal, they're not trying to murder their loved one. In fact, many of them are probably just confused, and they're sad that the person's in pain, and this is legal, and it could be something like that. So I can understand that objection to the word kill. However, we also should use words to mean what they actually mean, and it is killing just objectively. What killing is taking a being that's alive and doing something to it on purpose to make it be dead. And that is what euthanasia and physician-assisted suicide are. And the thing you do to the being is give it an overdose. So it is killing. Okay. And that's the whole point, by the way, if you think about it, of euthanasia and physician-assisted suicide. That's what they want to do. You'll see in the bill, they like to avoid not only the word kill, but the word these words homicide, suicide, genocide, that side at the end. It's from occidere in Latin, it means to kill. So suicide is to kill oneself, homicide to kill a person, genocide to kill a lot of people. Okay. Where So the two sides do agree that that's what's happening. Where they disagree is that the pro-life or the Catholic side says that killing a person because they are sick is always wrong. It's never justified. The pro-euthanasia, or we can call them the pro-choice side, although I'm going to talk about that word pro-choice a little bit later, says that killing a person because they are sick is not always wrong. So that's a disagreement with the Catholic view. Sometimes it's justified, and they even argue that sometimes it's morally obligatory to kill the person, if it's what they want, and so on and so forth. Okay, I know this is a little bit heavy, but this is the basis of it until we get to the teaching. So there's 3 types of physician-assisted suicide and euthanasia. One is called voluntary, and that's when the patient asks to be killed. And that's what the Rhode Island bill is set up to do, to allow patients to be able to ask for that. And then there's non-voluntary euthanasia, which is when the patient has not indicated whether or not he or she desires to be killed, and they euthanize them anyways. And this is very common. It's very common in places like Holland, quite common. It's not quite legal, but they allow it in Holland. And we can talk about that. And then involuntary euthanasia is when the patient is euthanized against his or her own will or caregiver's will. And you might think, well, that's just straight up murder. And it is. But these things happen. These things happen. There's a famous story in Holland, again, in the Netherlands, where a doctor put some sedative in the coffee of a woman and then injected her with, he was about to, and she woke up and was fighting against him, and he injected her anyways. And then he actually got, it's a famous story in the news, and about 2017, and then he got, actually, it's so sad, her family members to hold her down because she was struggling against it, and finished that. And now, then there was a court case in Holland, I think it's sort of still pending, where they want to say he shouldn't be penalized because, and we'll talk about that on the third night, the spreading. Once you decide to allow it, it always spreads. Or the Charlie Gard case, you may have heard about the little boy in England. There's a lot of these little children in England who are very sick, and their parents just want to care for them. Or we'll talk about Terry Schiavo in a minute. You've probably heard about her. But the British government just decided against Charlie Gard and overruled his parents' wishes to have him treated and try to save his life. And this has happened like 3 or 4 times in England. So there is even involuntary euthanasia. Okay. So the Hippocratic Oath, you may have heard of Hippocrates from 500 BC, which is where we get the Hippocratic Oath from, which is what doctors say, or you could say, used to say, at their graduations. And the Hippocratic Oath is very long. Not long, but it's like a page or 2 long. But I just want to pluck out one sentence from the Hippocratic Oath, which pertains to our topic tonight. It's very beautiful and striking. So Hippocrates wrote in his oath, "I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect." It's quite striking that, first of all, and the next part of that quote, he also says, "I will never do an abortion." First of all, it's amazing that 500 BC, it's almost like a precursor to the Gospel of Life of John Paul II. Hippocrates was seeing the dignity of the person, the preciousness of the person, and he grasped in some profound intuition that to kill a person because they're sick is a profound violation of the preciousness of a person. A little bit later, we'll get to some of the reasons for that. And so nowadays, what we're doing is legalizing, I put 180 there to remind myself to say, it's a 180. Up until recently, doctors said the original Hippocratic Oath, and what they vowed is they would never use their medical knowledge, their medical skills, their medical training. They would never use that, and they'd be the best at it because of their training. They would never use that to kill somebody. They vowed. And now we're doing a 180. We're saying now we want doctors to use their skills and training to kill some people. That's a 180. It's not good. And that, which I'll explain probably on the third night, is the real reason why the restrictions on euthanasia never hold, because we've done that 180. And then I've always been struck by this second clause of that quote. Not only did Hippocrates say, I will never do this, he said, I would never even suggest it to a patient. Are you kidding me? He was horrified at the thought of telling a patient that they might kill themselves. One of the things I want you to think about now is I would suggest that all these euthanasia laws that are passed are not just the doctor, but all of the healthy and all of the society suggesting to sick people that they might kill themselves. It's a real abandonment of the sick. It's a statement it's a statement of society of abandonment towards the sick to legalize it. And Hippocrates saw that. He didn't just say, I won't kill the sick. He said, I'm horrified at the thought of even thinking about suggesting it to them. I want to love and care for them. It's amazing. Okay. So a definition of euthanasia, we need this. And this goes also with physician-assisted suicide. So this is from the Declaration on Euthanasia, which is published by the Vatican. So euthanasia is an action or omission, and I'll define those, which of itself or by intention causes death in order that suffering may be eliminated. Okay. Okay. Euthanasia's terms of reference are to be found in the intention of the will and the methods used, or what's called the moral object. So, I know that's a lot of complex words there, but intention is like whenever you want to do something, you have a goal in mind. That's your intention. You want to help the poor. Intention. You got to pick some way to get your goal accomplished, your intention. So you might make a soup kitchen or something. In this case, the intention is, I want this person's suffering to be less. That is a good intention, to want people not to suffer. But the question is, what are you going to pick to accomplish that goal? And here, euthanasia is picking to accomplish your good intention of wanting their suffering to be less, picking killing them. That's not allowed. That's intrinsically a moral thing to pick. It's nice to want to have their suffering go down, but you got to pick something else, according to Catholicism. Okay. Now, sometimes in some cases of euthanasia, there's also the intention, sadly, of wanting the person to be dead, and that gets more morally problematic. Okay, you may have seen these two people. So the first one is Brittany Menard. Oh, thank you. She was 29 years old in 2014. She lived in California. It's legal now in California, in large part because of her. And she went to Oregon, where it's been legal for quite a long time. She had a brain tumor. It wasn't cancerous, but it was big. And I know somebody who has that same exact thing, and he's still doing fine. 10 years later, he wrote a letter to her not to do it. But and she went to Oregon and got the prescription and ingested it herself, and her husband and her mother helped her get there and everything. So that would be an example of euthanasia by action. Remember, we had action and omission. So by action is when you do something. You ingest an overdose somehow, or a doctor gives the person an overdose. And then the next one, Terry Schiavo, you probably all know who she is. Terry Schiavo, it was in Florida at the time. The most important thing to remember to understand the Terry Schiavo case is she was not dying. She was not dying. She needed help getting nutrition into her body, but she wasn't dying of anything. And her family just wanted to bring her home and care for her. And Judge Greer, after the whole case of the news and everything, and the Bushes trying to stop it and letting it go and all that, he issued his final order to remove the feeding tube. And she died a very gruesome death of about 13 days of dehydration and starvation. And there was a police officer in the room the whole time. And her mother was so distraught. The family took her out because he didn't even, the police, I know this is macabre, but the police officer didn't even let them put lip gloss or ice chips. That's how strictly so it's terrible. That is euthanasia by omission, not doing something like feeding her, okay? And the other one, injecting an overdose, is by action, okay? So there are actually 3 positions on euthanasia that's very important to point out. One is the Catholic pro-life one, which I'm developing. The other one is the pro-euthanasia, pro-choice one, which I've been developing a bit. And then there's one we could call vitalism. And many people wrongly equate the Catholic view and the vitalist view. And they're not the same. And I'm going to show why here by making a fundamental distinction. So another fundamental distinction in Catholic teaching is the one between extraordinary treatment and ordinary care. So extraordinary treatment, to begin with, we can say it's medical treatment which, if removed, the pathology or the disease will kill the patient, okay? And an example of, so when I teach this for the first time, like to the students, I like to use extreme or clear examples. So an example of extraordinary treatment that's easy to understand would be if a person had cancer and they do a round of chemo, and then the cancer comes back, it's stronger than the chemo. And then let's say they do another round of chemo and the cancer comes back, it's stronger. And then the doctor says, you know, we have another protocol, another recipe, if you will, of chemo, would you like to try? And if the patient says, you know, no, I've had enough, this is too hard, that is allowed in Catholic teaching. That is refusing extraordinary treatment, okay? It's a simple way to understand it. I might talk about those points about futility later. Ordinary care, on the other hand, is medical treatment or basic caregiving, which, if removed, a patient who is not dying will die. That's what happened with Terry Schiavo. She wasn't dying of anything, and they just stopped feeding her. A simple, maybe even to make it more clear, just let's say someone couldn't feed themselves, but they just needed to be hand-fed. They didn't need a feeding tube. And let's say it was your job to do the hand feeding. And then you just say, I'm not doing that anymore. You just stop. Then they die of starvation. That would be not giving them ordinary care. That would be euthanasia by omission, okay? So, and now people want to know, is it morally acceptable to refrain from or cease medical intervention? That's a good question. And the Catholic pro-life response says that ordinary and proportionate care are morally obligatory. So it is not morally acceptable to refrain from or cease ordinary, or what's called proportionate care. And that means for the doctor or the patient. So, and there I put nutrition and hydration again. I'll talk about that more later, but Terry Schiavo had her nutrition and hydration removed. That was ordinary care. That violated a moral obligation. But we may, in the Catholic view, forego extraordinary and disproportionate treatment. It's morally optional. You can choose it or not, and it's up to you. It's up to you. So that person I mentioned before might say, if the doctor says, you know, if we do the 3rd round of chemo, let's say he says, you'll have 1 month to live, but if we don't, you'll have 1 week to live. Maybe the person's waiting for someone that they want to talk to who's not there yet. That might be a reason to choose it. It's up to the patient to choose or not choose extraordinary. But ordinary care is, according to Catholic teaching, morally obligatory. I'm talking in terms of obligation right now, but later I want to show that it's connected to love for the patient. So why may we forego disproportionate care? I mean, the main reason is death is unavoidable. All of us are going to die. And so if somebody says, I don't want this extraordinary treatment, the way to describe what that act is it's the humble acceptance of the approach of death. That's what that is. It's the humble acceptance of the approach of death. They're dying of something. That is not killing. That is accepting the reality of death. Ordinary care is continued throughout lovingly, and the patient dies a natural death of his or her illness. And to die, and I'm going to talk about this at the end, is a human act. It might sound funny, but going through the dying process is actually a human act, or many acts. And some writers say that it's actually the most important thing you'll ever do in your life, how you go through your dying process. And that used to be known among Catholics. I think we've lost this idea of an ars moriendi. And I'll explain what that is in a minute. So extraordinary treatment is optional. Just to show you that what I said is in the Catechism. It says discontinuing medical procedures that are burdensome, dangerous, extraordinary, or disproportionate to the expected outcome can be legitimate. It is the refusal of overzealous treatment. It's one of the reasons this comes up. That's our problem in our day and age, because medical technology is so advanced. Overzealous treatment is actually a problem, which connects to this idea of vitalism. But vitalists, I guess I never defined it. That's the view that says it's morally obligatory to do everything. You must do the 3rd round of chemo and the 4th round of chemo. It's almost like people who have the vitalist mentality almost want to deny that death is real. But that's not Catholic. The Catholic view is death is coming for us all, and there's a way to prepare for it and go through it and to accept it when it's present. Here, the Catechism says, one does not will to cause death. One's inability to impede it is merely accepted. And then it says, the decisions about foregoing extraordinary treatment should be made by the patient if he's competent and able, or if not, by those legally entitled to act for the patient, whose reasonable will and legitimate interests must be respected. And some people think, well, if the church leaves it up to the patient to decide what is extraordinary, doesn't that just make it willy-nilly moral relativism? They can pick whatever they want? And the answer to that is no, because in each situation, and each situation is different, it takes work and thought and prayer and discussion with the family and the priest, and you can actually discern which treatments or care are ordinary and which are extraordinary in a specific situation. And then once you discern that, then comes the moral obligation to accept the ordinary. And by the way, sometimes it's a big sacrifice, like Terry Schiavo's family, but they wanted to do that sacrifice because they loved her so much. Or caring for people who, let's say, are in a coma but not dying of anything for years. So sometimes it's challenging, but you can discern it. Now, there are difficult cases, and I'm going to talk about one of those, a theory about that in a minute. So ordinary care is morally obligatory. So the Catechism says, even if death is thought imminent, the ordinary care owed to a sick person cannot be legitimately interrupted. Okay. Now, years ago when I was giving this talk, I noticed that people always wanted me to give them a list of ordinary care so they could have it in their back pocket and know which things they're supposed to do. And strictly speaking, you can't make a list because every situation is different. But I got this question so often that I made a list. So I'm gonna show you the list, and you can tell me what you think of it. And I will say that when I've given this talk, like tonight with the medical doctor present, sometimes I've been corrected by clinicians or other people, and I appreciate that. And I'll tell you about some of those as I go through my list. So one is artificial nutrition and hydration. If the person's body is assimilating food and water, and maybe they do need a feeding tube, but there's no difficulty in supplying nutrition and hydration that way, and they're not dying from anything, then the church teaches that it's ordinary care, even with a feeding tube. Feeding tube as such does not make it extraordinary. If there's other complications, then it can become extraordinary. Cleanliness, obviously ordinary care. Comfortable room temperature, bed care. I just made up this story because like imagine you had a loved one at a home and you went to visit them and you realized that they had bed sores. And what if you went up to the staff and said, why why does my loved one have bed sores? And what if they answered, well, because we stopped doing the care that makes that not happen? And if you said, but why did you stop that? And if they said, oh, because of love and compassion, that doesn't compute, right? Stopping ordinary care is the opposite of love. It can't be loving to stop ordinary care. All these, if you stop them, you're by necessity abandoning the vulnerable person. Appropriate rehabilitative care, monitoring for signs of recovery, blood transfusions, maybe not in some countries, antibiotics. This is where I once got corrected by a doctor. The idea here is that if a person has a secondary infection, maybe unrelated to their primary pathology, and antibiotics would help relieve that, then of course that's ordinary care. But one time a doctor told me, however, in some diseases, antibiotics can be counterindicated because it causes other problems, and so therefore, in those cases, antibiotics would not be ordinary care. So, insulin, this one's a true story. So I was teaching this once to a class, and one of the students raised his hand and said, I got to tell you something. He told the whole class. They had an elderly, let's say it was his grandfather, and he was a diabetic and needed an insulin shot, and the caregiver, and he was sick in other ways too, and the caregiver said, should we just skip that? And he said, we were just all horrified. Now, I can't, and they said no. And I can't, I wasn't there, I can't judge the mind of the caregiver, but the idea that the kid was suggesting was that the caregiver was just trying to throw in more things to make the person die quicker, when really the insulin would have been a comfort in ordinary care. So the euthanasia mentality had infected that caregiver, okay? Okay. Some forms and cases of assisted breathing, it's sort of like nutrition and hydration. Obviously, some people are perfectly fine and they just need a breathing help. And if you take it out, they'll suffocate. Whereas other people, like in intensive care or other cases where there's a disease going on, then removing the feeding tube is legitimate. Palliative care, that's the whole question of, yeah, I might skip that. But you do have to be a little bit careful with pain medications. We want people not to be in pain, but sometimes A, they can be overused, and B, it's a consideration to help the person stay as conscious as possible so they can make a good confession or talk to their loved ones, and so not just knock them out. So to make life easier for the, okay. Most important, personal relating, attention, affection, spiritual. Okay, important clarification about legalizing physician-assisted suicide. I said before, sometimes it's difficult to discern extraordinary and ordinary. So intention is not difficult. If somebody's intention, I want them dead, that's not good. You can tell if someone's thinking that, then it's not good. And I also want to distinguish the intention to kill someone, which is bad, from the experience of relief when the person finally passes and they're not in suffering and you're happy for them. That's good, that's okay. It's just, that's not the intention to kill them. That's a wonderful actual feeling. It's mixed with the sadness that they're gone. But so in this case, you pray, discern, discuss, talk, and then at some point, you just trust God that you did the discernment and you decide, okay, I think this one is extraordinary. We're going to remove it now. And you just do your best. You don't intend to kill, and your whole intention is to love and care. You would never stop that. And then, okay. Now so these bills, like the Rhode Island bill to legalize this, is not about that difficult discernment process. That's beautiful. The bills, and I just want to make this clear, it's about legalizing the delivery of a lethal dose to kill somebody. That's what the bill is about. It's not about the wonderful, difficult decision of loving and eventually deciding to remove. Sometimes people in the pro-euthanasia movement say, you guys are in favor of euthanasia too, because sometimes you will stop, this or that machine. No. That's just stopping extraordinary care, and we're still giving them ordinary care. We're not killing them. Okay. Does the legalization of physician-assisted suicide or euthanasia increase freedom or decrease freedom? So that people on the pro-choice side say, well, we're increasing choices, so it's more freedom. People can pick it or not pick it, more freedom. But I think we can make an argument that it's actually decreasing freedom, not increasing freedom, to legalize this. The legal permission for assisted suicide plants in vulnerable minds the belief that they are a burden. It creates a sense of abandonment and the implication that one should be dead. And soon the right to die feels like a duty to die. So what happens in a place where euthanasia is legal is people who are sick and vulnerable have thoughts enter their mind. Like, maybe I'm taking up space. Maybe people don't want to take care of me. Maybe I should do this. But in a place where it's illegal, there's just an confidence. You just know everyone loves me. They're going to care for me. Nobody's going to kill me. So what I want to say, when I went back to Hippocrates, when he said about, I would never suggest it. And then I said, the laws are one big suggestion of the healthy to the sick. Legalizing physician-assisted suicide unavoidably contains a coercive element because of the thoughts it makes arise in the vulnerable person's mind. And coercion is the opposite of freedom. That's why legalizing it is not more freedom, it's less freedom. And as I'll talk about on the last night, it always expands. And there's different opposites to love. Hatred is the most obvious one. I don't think that people hate their loved ones they could, which would be sad, who are participating in this. They might even just be confused and think they're loving them. Using people is another opposite to love. Sometimes this happens too, like maybe if they want the inheritance sooner or something. But hatred and use are not the intrinsic reason why euthanasia is the opposite of love. Abandonment and indifference to somebody is a third opposite to love, which is different than hatred and use. And this is intrinsic, I think, to euthanasia. We abandon the sick when they're most in need of love, when they're most vulnerable. And the sick person, they feel that abandonment. And that's why I would suggest they request euthanasia. In fact, there's been studies done. Pain is like one of the lowest reasons why people pick it. They often feel lonely or abandoned, or like they say, losing their dignity, by which you can't lose your dignity, by which they mean, someone has to wipe them. It's embarrassing or something. But if they could feel that people love them and they want to be with them and help them, then they don't ask to be killed anymore, okay? So why is death a human? After this slide, I just have pictures and then we'll be done. If you ask people today how they want to die, what do they say? Inner sleep. They don't even want to know it happened. There was a prayer that Catholics prayed regularly. "O Lord, deliver me from a sudden death." Catholics used to actually regularly pray for the exact opposite of what everyone today wants. What did we lose? Going through the dying process, you'll probably make the most sincere confession you've ever made in your life. You'll reconcile with people, speak words that you've been afraid to speak. There's earthly redemption and supernatural redemption that happens. Consider your life more deeply than ever. Speak to younger relatives. Prepare for your death. And physician-assisted suicide and euthanasia just eliminates all that. And people before knew that the dying process was important. And that's why they used to pray not to have a sudden death. So these are two images. The one on your left is by John Lorenzo Bernini. It's in Rome, and it's death with a blanket made out of marble, because you never know when death is coming, but he's holding an hourglass, and he is coming. And it's over the tomb of Pope, I forget which Pope, Pius VII maybe or something. And the Pope used to walk under that. Now the sacristy is in a different place in St. Peter's. But the idea is this memento mori, means remember your death. After the Pope is up on the papal altar and everyone's worshiping him kind of, he would walk under that and remember, you're going to die like everybody else. It's a way to, it's a Catholic practice, or sometimes you see paintings of saints with a skull on their table. This idea, not all the time, but once in a while to sit down in a quiet moment and say, not death happens, but I'm going to die someday. I don't know when, but it's going to happen. And you just sort of ponder that a little bit in a quiet moment, and it helps you prepare for it. That painting is by, believe it or not, Pablo Picasso. I think it's called Science and Faith. And you notice there the doctor, he's still there holding the woman's wrist. But she's looking away from the doctor because medicine has done its work, towards the nun who represents faith and the child who represents family. And so she's turning towards the important things to think about during the dying process, now that it's actually happening. That's the whole tomb where the Pope would walk under. There were, I don't know if you can see this, but in the 1300s into the like 14, 15, 1600s, there was this idea of ars moriendi. And a lot of times it happened in plagues and so forth when there weren't many priests around and people were dying. And what they did was they created books for people to look at, to help them go through the dying process. So these ones are lithographs. The last one is going to be a color one coming up. But it's really striking what they did. In this Ars Moriendi book, this particular one is recently translated. You can get the book from the National Catholic Bioethics Center. So what they did was they would put an image of one of the temptations that hit people a lot when they're going through the dying process, and next to it, the corresponding virtue, okay? So this one, I don't know how well you can see it, but over here, the man, you can say he's all frustrated, he's kicking, his leg is kicking his sheet off, he's kicked over the food bowl, and the nurse has consternation on her face. There's devils under his bed, kicking underneath his bed. And so he's suffering the vice of impatience. And then the one next to him, the devils are sort of fleeing. He's surrounded by the angels and saints, and he's in a state of patience. And so people would look at these pictures and say, okay, when I go through the dying process, patience is going to be a particularly difficult thing to overcome. And then I look at this and I get help. The next one's a little more striking. So the temptation is attachment to worldly goods. So if you look at this picture here, if you can see it, the man's laying in his bed and you can see a devil next to him. And he's like, look, your house, your barn, your horse, your servant, someone else is going to get them all. So you have this attachment to worldly goods strikes you when you're getting close to death. And then next to it was no house in the picture, no barn, no horse, no servant, replaced by Jesus, naked, with nothing on the cross. And you look at that and you say, okay, Jesus, you did this with nothing, I can do this. It's very beautiful, like expressing the virtues and vices at the moment of death via images. And then the last one, I just picked those two, but the last one in this particular book is the man is dead, and if you can see up by his head, there's an angel pulling a little body out of his mouth, which represents his soul, right? And the devils are all mad. Why? They lost a soul. He made it to heaven because he practiced the art of dying, the ars moriendi. Okay, just two more pictures, and then we're done. So this is another very common type of picture that would appear in these books. Remember at the very beginning, the first slide, I said, is the sick person placed at the center of attention, or is the sick person abandoned, ignored? So in this image, which people would look at in their books, you see the man who's sick in the geographical center of the painting itself. And then we can talk about the different things in the image. So the big cushy cushions under his head, pillows under his head, represent comfort. And maybe his sister or his sister and his cousin are holding his hands and touching him. In the foreground is the priest preparing the sacraments for the man. The woman in black could be a nun praying, or maybe his wife already dressed in mourning praying. The two guys behind the women holding the man's hand, probably his friends preparing his will. The man in the background, I don't know if you can see him very clearly. He looks like a doctor checking a urine sample. He's got a glass bottle with some yellow liquid in it. So all those people are surrounding this sick man. And I used this painting for years, and I showed it to a friend of mine recently, and she said, look at the window. And I was like, oh, the window has 3 dark panes, which represents the fact that death is hard to go through and suffering and death are difficult. But it has 1 open, bright pane, representing eternal life. So people would look at that. When people were inspired by a painting like this, like they would be loved like this through their dying process, now you can understand why people prayed, "Oh Lord, deliver me from a sudden death." Now I have one more picture. Before I show it, I want to say that I'm grateful for modern medicine. I've benefited from it greatly, actually, myself, and probably all or most of you have too. So the next picture isn't a complete slam on modern medicine. However, there are some problems with it. I just want to contrast this picture that you see here with this. So there you see the woman is holding a metal bar, not a human hand. And they're in an ugly room with a drop ceiling, and they're just all lined up. And nobody's really even paying attention to her. And maybe these are some of the reasons why people of our day and age are drawn more towards euthanasia. Because if it's that lonely and painful, who would want to be there? So I think what we need is an Ars Moriendi for the 21st century. And I know on the third night, the Little Sisters of the Poor are going to come up and talk a little bit too, because we have this in them. We have Catholic-run hospices, but in general, we have a problematic culture when it comes to death. But there is beauty. I'm going to leave, I know it was a lot of heavy stuff, but I'll leave this beautiful picture up for the rest of the time here. So, okay, the end. And maybe, so Dr. Flanigan is going to come up, and he's a very accomplished medical doctor at Brown University, infectious disease doctor, and a Roman Catholic deacon. And we go around together doing this talk. So, all right.
Thanks. It's good.
Thank you.
Thanks a ton. I was a little worried because I'm a deacon at St. Teresa and St. Christopher's Church in Tiverton, and we just stole your priest, Father Dufour. So I said, uh-oh, Father Dufour, I hope nobody's going to throw any rotten tomatoes at me. We're so lucky to have him. It's really great. So yes, it is true. I am a physician. I went to Cornell Medical School and then did my residency in Philadelphia, UPenn, and I did an infectious disease fellowship at Case Western Reserve University and was on faculty there. And then I came to Brown in 1991 with my wife, Luba, and then our 2 kids. We then had 3 more kids, a great, great blessing. We now have 1 grandchild. And then 10 years ago, I was ordained a deacon, a permanent deacon in our diocese, which I love, and I have great fun talking about that as well, because it's been a great blessing in my heart, in my life. So I have done a lot of end-of-life care, particularly in the first 2 decades of the HIV and AIDS epidemic. And that was particularly hard because parents were caring for their children who were dying. And that's not the way it was meant to be. It was meant to be that we take care of our parents near the end of life. And it is so hard, so hard. It breaks your heart to see a parent struggling with the sorrow and pain of their own child who's very, very ill, and where at some point nothing can be done. So I want to share with you some of the lessons that I've learned, and some of it will be through stories, about the challenges at the time of dying. I love coming after Peter. He is so clear, and he's such a gift to our diocese and to so many folks, the way how he walks us through it and how important it is. I'm going to talk a little more, I would call it anecdotally by telling some stories. So Donna Blaze worked with us for about 20 years, had a heart of gold, and she comes from a large Italian family and gave me permission to tell this story. Her mother was 92 and was diagnosed with pancreatic cancer. And as many of you know, pancreatic cancer is a terrible disease and is often...
Hold the yellow button down.
Oh yeah, thank you.
I can't. Oops. You can use my. Oh, there it goes. Okay. Don't want to miss one word.
Oh, there you go. And pancreatic cancer is often not responsive to chemotherapy, and she didn't have the stamina to be able to really endure safely the significant side effects of chemotherapy. And so after discussions with her family and her physician, she said, no, I want to just be taken care of at home. And Donna and her sister went and took care of her. As she got weaker and weaker, they had to help her go to the bathroom. She could get out of bed only with assistance. They would each take one arm. They would walk her to the toilet, go to the bathroom. Then they'd have to, wipe her bum and help her stand up, because as you all know, it can be difficult. You lose that strength in your thighs to be able to lift up, and bring her back to the bed. And while they were walking her back to her bed, her mother turned to both her and her sister and said, I have the 2 most wonderful daughters in the whole wide world. Donna then said, we couldn't believe it, because she was the matriarch of our family, tough as nails, and never in our entire lives had we heard her say that to us. It was only when she lost her dignity in many ways. And one of the greatest fear of people as they come close to the time of dying is that you will lose your dignity. And the dignity in the sense that you become dependent and you become vulnerable. You cannot clean yourself. You can't brush your teeth. You can't clean yourself up. The things which we hold most dear to us and to our heart. This is part of who we are as a person. And that is stripped away. Peter described it there at the end. We come into this life naked and helpless. We leave this life usually naked and helpless. And in that, we become in need of the tender, loving care of others. And we lose the ability often to provide the care for ourselves. So we lose that sense of who we are, and it's stripped away. It is a hard, hard thing. And yet, it's a time of such tremendous love, because as family members or friends, we can provide that care and show the person we love, no. It's not how well you can do your hair that your dignity is the source of your dignity. It's that we love you. And you see yourself through the love of others. And that is so extraordinary. When Donna told me this story, she literally had tears in her eyes and was crying because of how much it had touched her. A whole other aspect of dying, which is very hard, is the frank reality of human suffering, both one's own suffering and watching a family member suffer. When my mother-in-law, who died with us right next to our home, but died in her own bed, which is what she wanted, she was not uncomfortable because she was in hospice care, and our current medications to relieve pain are really very effective and are very safe. It's usually a combination of medications, both medications such as morphine and often a medication such as Ativan. But the last 2 days of her life were painful to watch. It was painful for me, and I'm a physician. It was very painful for my brother-in-law, her son, to be with her when it was hard for her, taking those last few breaths, And it was clear that her body wanted to stay because our bodies love life. Our bodies are a gift. We are part of this created world. How extraordinarily beautiful that is. But there is a time where we have to go. But our body wants to hold on, to love life. So it was difficult to watch. She was not in pain. She was appropriately treated with pain medications. So, it was painful to watch. I helped take care of a very wonderful younger woman who unfortunately died of terrible, very advanced lung cancer that was refractory to all therapies. And her sister, I had to spend a fair amount of time with her sister to let her know that she actually was not in terrible pain, that our pain medications really do work. So relief from pain and suffering, our medications are very, very helpful, but it's painful for others to watch. And we are all scared of this. But our medications are effective and are good, and thank goodness for them. They really are a gift. But it's important to say. We also know from our Catholic faith that all suffering, that God uses all of reality, all suffering, for the good. And that suffering, of course, in the Jesus's gift of self, where he willingly gave himself, that the suffering of Jesus is our salvation, is our redemption. And that our suffering can be joined to Jesus' suffering. And what I say to people is that Jesus made it clear that we are never alone. We do have to carry our cross, but Jesus carries our cross with us. And Jesus asked Simon of Cyrene to help carry his cross. And in some mysterious way, I believe that when we offer up our suffering to our Lord and Savior Jesus, that we somehow join in that redemptive act of suffering for the salvation of the world. Now, there are other parts that are very of the whole death and dying process that unfortunately has pushed our culture towards what I still call physician-assisted suicide, but which, as Peter mentioned, is now called MAID, which is medical assistance in dying. I hate that term because we all want medical assistance in dying. When I'm dying and I'm short of breath, yes, please give me some oxygen. Yes, if I'm in terrible pain, please give me appropriate pain medications. We all want medical assistance during the time of dying. But they have created this new term in order to confuse people. And it's much more acceptable to say, wouldn't you like to have medical assistance in dying? And that's an easy thing to say, well, it sounds good to me. So I am very much against that term. Our current medical industry, unfortunately, does often push to overly emphasizes interventions. So much of our entire medical culture surrounds the inpatient, hospital, interventional experience. Payment is heavily weighted towards interventions. And You know, if you're a carpenter, you love to pound nails. When you're able to do a great intervention, you want to do that intervention. So we naturally intervene, and the natural place of that intervention is in the hospital. So most of us want to die in our own beds, surrounded by the care of our loved ones, and the entire system conspires against that. So this 3-session talk is really important for this. But it's so common, unfortunately, for folks that have severe chronic illness with no reasonable expectation of significant recovery to end up in the intensive care unit on a respirator that's breathing for them, which is not routine care, but which is really a heroic intervention. And as Peter mentioned, our Catholic faith teaches us that routine care is always appropriate and should never be denied, but that heroic interventions do not have to be, we are under no moral obligation to either impose it or folks to accept it. You have to discern whether it's appropriate for you. But yet, time and time again, in our intensive care units, it's often more common than not that our folks that are both on respiratory support, blood pressure support, kidney support, GI support, have conditions which have no reasonable chance of any recovery. And when you see that with a loved one, it quickly makes you recoil and say, what are we doing here? And it pushes people towards the physician-assisted suicide arm. So it's really a sad situation. The last area that really deserves mention is when we are ill, severely ill, and we are uncomfortable and feeling poorly and are nauseous and are losing weight and are not thinking clearly, it is normal to be depressed. It's normal to be depressed. Whenever you have a terrible case of influenza, which you recover from totally, COVID, which you recover from totally, really, really bad urinary tract infection where you have a high fever and you're shaking and you're sick as can be, you feel awful. And when you feel awful, it's normal to be depressed. So that this sense of, what am I doing here? Is it worth me even living? Can be very, very, very strong. The antidote for it is just what Peter said. Is somebody sitting by the side of your bed, maybe just holding your hand and stroking your hand. Maybe it's saying a rosary out loud. Maybe it's just being there with some music being played with a hand on your shoulder. When that happens, you go, wow, I am worth being loved and cared for. But it's quite normal when we're in the throes of a chronic illness to become depressed and feel it's just not worth it. We shouldn't blame or judge anybody who has that response. We should just say we need to go to them and just be with them and not tell them how to feel, but just be there with them. The look in our eyes is more important than anything else, and that is what makes all the difference. But as Peter said, I happen to agree with him very much that one of the great evils or consequences of normalizing physician-assisted suicide is the message that yes, you really are not worth. It's not a question of being worth sustaining life. That's an important principle. But a deeper principle is you're not worth being loved right now. We should just end it. And by the way, that will probably lead to less cost. And by the way, it's also so much more convenient because your family member wants to be there when you pass, and they've got a job, and they've got kids, and there's a lot going on in life, and they don't want to miss everything. Couldn't we just help make this possible? It's a very scary thing. So the antidote is the TLC, the tender loving care, and being present for folks during that difficult time. We cannot relieve the fear of loss of dignity. We cannot relieve discomfort. We can help with pain, but not with discomfort and not feeling well. We cannot relieve the depression or sense of loss, but we can be there and say, I want to be here with you and provide you care. Now, the last reason, or one of the last reasons people sometimes have great difficulty at the time of death, is the existential question, what's going to happen to me? Is there anything beyond this life, and what will happen? My own father, who was quite successful, was quite scared about all that's in the gospel about, what's going to happen to the rich man. It does not sound good. And most of us in America are quite well off. We're all 1%ers compared to the world. We're actually 0.001 percenters. And he was really quite worried about it. My stepmother had a near-death experience. And the joy that she experienced during that time was so intense she had trouble putting it into words. And there's now a deep literature about near-death experiences and end-of-life experiences. I particularly like a book by Mary Neal, MD. She's an orthopedic surgeon, and orthopods, as they are called, are quite to the point. Let's get this thing done. And she underwent a very, very powerful near-death experience during a kayaking accident, and she talks about it in a lot of detail. And the book is called 7 Lessons from Heaven. Not a very good title, 7 Lessons from Heaven. And there are many books and movies out there. And in fact, Angel Studios, which just made the film Sound of Freedom with Jim Caviezel about childhood sexual trafficking and predation, just is coming out with a new movie right now about, proof. It's not proof, but it's obviously evidence for the other side and near-death experiences. And the almost near universal theme is not just the light in the darkness or at the end of the tunnel, but the embrace of love, which is so, so powerful. She actually, in her book, talks about Jesus coming to her and talking with her. And if you read the diary of St. Faustina, she believed that Jesus comes to everyone who has died 3 times to be there with that person, and more than once. And of course, it's the message of divine mercy and the message of extraordinary hope for all of us. But many people don't have that belief or that faith. And many Catholics, practicing Catholics, still have trouble. That's okay, because it's human. It's our humanness. And again, being there, saying the rosary, just saying you believe that Jesus is there, Mary is there with you at this time is the best antidote. One of my fellow deacons' wife is a hospice nurse, and she was with a patient at 3 a.m. and was praying for her and praying the Holy Spirit would be present. And she's a very down-to-earth, very practical person, as so many nurses are. And she told me, she said she was praying and keeping her eyes open, and she looked up and there was a flame above the patient's head. And it was there for about 12, 15 minutes. But for her, and that was there for her to see, it was really that the Holy Spirit was visibly present at that time. And there's no question that what divides us from the other side is not a concrete wall, but a very, very, very thin curtain. And they are there to help us, and we are there to pray for them. This is a dynamic, life-giving, grace-filled act of love. And that is what the community of saints is all about. Not just the community of saints, folks in heaven, but also those in purgatory. We're supposed to pray for them, help them. And I believe they also help us. It's very beautiful. So we have to realize where we're at in our culture and do our part. But the reality of how we view suffering and death can make an enormous difference to those who we love. Great. Peter and I now will take all sorts of questions of any sort.
I'm not sure why they're not functioning.
Yes.
Can you explain or expound on whether morphine
Yeah, I'm gonna see if I go near it, if it does it better.
Sure. Morphine, it does not, given it the regular doses in order to treat pain, does not cause organ shutdown. Now, there are times where that high doses of morphine will put someone into more of almost like a stupor. And that one of the main issues there, and one of the reasons why near the end of life we don't feed people at the very, very end of life, for example, the last 24 hours, is that the bowels that can stop working, and when the bowel stops working, somebody can throw up, and if somebody throws up and they're absolutely in a stupor, they can aspirate everything go down their lungs, just like somebody who's very, very healthy, who's a 19-year-old can drink so much, can vomit, aspirate, and die, because alcohol is a sedative as well. Usually, though, when individuals are in pain, they are epinephrine up. Their blood pressure is high, their pulse is high, they're wide-eyed, they're in terrible pain. For example, a broken arm, or terrible substernal chest pain from a terrible heart attack or an MI. When somebody is in that situation and you give them morphine, the edge is taken off. They know they're in pain, but the edge is gone. And they're able to just can deal with the situation much better. So when you're having a heart attack, one of the standard forms of therapy is morphine. Why? Because it helps you from that fight or flight response, which is natural. So morphine really is a great blessing. Obviously, opiates are addictive, misuse, overdose. We're all familiar with that. But by and large, these are very, very safe medications. As I say, they can be overused, and there is that situation if somebody is literally stuporous and unarousable, that you could aspirate, you could vomit and aspirate, or the blood pressure could drop due to too much of the opiates. Yes?
I wanted to just have a clarification of feeding tubes. If it's extraordinary or ordinary,
Yeah.
and in what situation?
Well, not being a clinician myself, I probably can't give you specific medical things he could, but basically there was a battle between the bishops of Pennsylvania and Texas, both sincerely wanting to know the answer in the early 2000s. And the question they sent to the CDF was, are feeding tubes always extraordinary treatment? I'm paraphrasing it. Nobody knew. And then the CDF wrote back finally in 2007 and said, no, they're not always extraordinary. Sometimes they're ordinary treatment. And the easy way to explain when they are ordinary treatment is when the person's body, unlike what the doctor just said, is assimilating food and water just fine, but for some reason they can't take it through their mouth. And they're not dying of anything. And so there's no infections at the site or all the other problems that can happen. And then you use one of the forms of feeding tubes to get nutrition and hydration into them. So if you're in a country where they have that, it's not expensive, and otherwise the person would die of starvation and dehydration, not of some disease, then it's ordinary care. And that was the answer the bishops wanted to hear. They wanted to know the answer. They didn't know what it was going to be. Once the CDF said that, they all got on the same page and said, okay, it's ordinary care in that situation. Now, there are times when using a feeding tube switches to extraordinary treatment. And when that happens, then it's up to the patient if they want to use it or not. And there are times also, as Dr. Flanigan said, when it actually becomes futile, meaning the person's body is not even assimilating food anymore. Futile is slightly different than extraordinary treatment, which is still working to some extent, but you can choose not to have it. Futileness, actually that word futile, now it has a different meaning. It has the traditional correct meaning of futile or futility refers to a treatment that is not achieving its end anymore. But now, sadly, because of this whole euthanasia mentality, the word futile in some of the literature has gradually shifted to refer not to the treatment, but to the patient. So in Texas, there's this law where hospitals can actually say to families, you have 10 days to find a place for your loved one. After those 10 days, we're not treating them anymore, even though the treatment's working. They say this patient is futile to us because it's taking too much work. Mm-hmm. But anyways, that's kind of a side point. But did I answer your question about?
Yeah, the reason I'm asking is, my elderly parents live with us, and I know that in their will, they don't want any extraordinary means, including a feeding tube. And
okay.
I just didn't want to have a moral problem.
Okay, that's a good question. And by the way, before I comment on that, from what I understand, and those of you who work in the medical field can, but I did read a beautiful article by a man named Brother Ignatius Perkins, who's also a nurse. He's a Dominican. And in his article, he says, the flip side problem with feeding tubes is that in many places, they use them when they don't have to save money, or it's sad, put a feeding tube in someone and stick them in a room, which it would more beautiful would be someone hand feed them and be with them. So the flip side is overuse of feeding tubes to save money and not have to hire people and things like this. Okay, now, next week is when we are going to talk about end-of-life documents. And in the first part of next week's session, I'm going to explain some of the things that will answer your question. But what's really problematic is many of the documents just produced by the states. So Rhode Island has this little green book. I don't know if we have it here. But Rhode Island, the Diocese of Rhode Island, has an end-of-life document that if you fill it out, you will still be Catholic. But many of these secular, if you will, or state documents don't discuss any of the moral things we were just talking about, and so you can check boxes. And they can check a box, no feeding tube. So checking that box would be actually inappropriate for a Catholic to check that box. Now, because, first of all, you don't know the best thing, this is going to be next week, but the best thing is to just have a healthcare proxy who loves you, knows you, and understands Catholic teaching, and knows what you want, and can make decisions in the moment. But if you check a box that I don't want a feeding tube, I don't want intubation, you don't, what if intubation for 2 days means you're going to have 10 more years? You don't want to check the box now. So actually, your parents, just checking that box, and by the way, this is very common. So what I would suggest it means is, sadly, most people don't know the basics. And so since they don't already have a Catholic ethos and thinking and knowledge of all this, it is going to be difficult for you to then go tell them, by the way, we can't check this box, because they don't understand everything we talked about tonight. Okay. Yeah, I didn't mean to. Right. So if you want to know what the church teaching is, the answer would be, it would be better not to check that box. And then when the person gets to the point where a feeding tube might be indicated, to try to discern whether it's ordinary or extraordinary. And if it's ordinary, then to have it for a while. That would be the Catholic answer. Okay, thank you for the question.
Yeah. So I totally agree. I agree with Peter, but I understand certainly why your parents have checked that, checked that box. So a classic example why you need a feeding tube is, for example, if you have head and neck cancer, in order to get the treatment, appropriate treatment, they have to radiate this part of the body. You can't really swallow. And so, but yet the rest of your body's fine. So that's a good example. Or you could have many people have a neurological condition and they can't, for example, can't swallow. Now, a safer situation when people really have a situation like that is often they'll put in a PEG, which is they'll put a tube that comes out of the stomach in that regard. But most of the situations are when people have severe chronic illness and they're near end of life. People very rarely die because of lack of nutrition. More important is hydration. And, literally people can go on hunger strikes for 100 days and they lose weight, but they come back and do fine. So but hydration, if you can't get water, that is really important. And by the way, being thirsty like that is very, very uncomfortable. So even people that are really not really what I would call compos mentis, they're just it's extraordinary. It's interesting. I've done this many, many times, and people say, "Well, I'm not sure they can't really eat anything. They might aspirate." Okay, I understand what you're saying. They're very, very ill, but you don't have to worry about aspirating water. You have to worry about aspirating what we call non-clears. But most clear liquids, ginger ale or water, you could literally have a cup of water in your lungs. You could aspirate, you'll be fine. Your lungs have the capacity to take that. But if you take someone and all you do is you put half a glass of water and a straw, and you put the straw to their lips, and people who don't appear to be aware of anything will take a sip, or ice chips, or spoon water, or helping them. And it's very interesting, a straw, maybe because the suck is part of our core being as a child or whatever, but people, if they'll bring a little bit and it helps the swallowing process, whereas pouring water down somebody's throat is not a good idea. It doesn't work. So hydration is so key. But as Peter said, it takes time too. But people near the end of life, don't worry. So often people are losing weight because of cancer. And the family members are saying, "Oh, but they're losing weight. We have to help them gain weight again because we love them." So they'll make up a wonderful stew and all they do is take 3 spoonfuls and they're nauseous because their body doesn't have the strength to really metabolize that. So it's rarely, near end of life, rarely is the issue nutrition, and it's much more an issue of hydration.
I just recently had a family member pass in hospice, and I did ask them about, can you give them IV hydration? And they said no.
Yeah, this is a tough situation. Did they pass at home or did they pass at the Hewlettar Center on North Main Street?
They passed in Massachusetts.
At a hospice center, inpatient hospice center. Yeah, I want to make a distinction. There's hospice at home and there's hospice in a hospice center. Hospice at home means nurses will come and visit. They'll try and make sure you have adequate pain control, make sure you have adequate TLC, and family members are by and large responsible for 90% of the care at home. And there they can do those things like we just talked about. Many inpatient hospice units have, on average, very short stays. And one of the reasons they have short stays is they do sedate very heavily. And when folks are sedated very heavily, you notice they're not even really interested in a sip of water. And you have to say, we're going to be here with our loved one and staying with them. And we obviously want them to have their pain relieved, but I'm going to be bringing them ginger ale or whatever, water or whatever, little things to make it clear that you don't want them what we call snowed. Snowed is really the medical term where somebody is overly sedated, so they're really not significantly responsive. This, I don't want to, it shouldn't be the case, but it's unfortunately that a lot of inpatient hospice units pride themselves on very short lengths of stay. And that's not really what it should be all about. But that's why when I've had family members say, gosh, we really can't take care of them at home. We think they probably have another 2 months, but we really can't take care of them at home. It's very complicated, why don't we just have them go to the hospice unit? And I say, well, the hospice unit, the average length of stay is usually like 3 to 4 days. So don't be thinking they're going to take care of your loved ones for 2 months. They don't. So that is an issue. And, frankly, it is a concern. And it's a concern. And, we just advocate. And it would be nice for folks to be able to have an option of IV fluids. And many patients find that would be nice to have that option.
And that's like, a very touchy issue, like how bad is it out there? But, and maybe it's really bad. We'd have to do a study. But the solution to it, it's kind of like a long game solution. What we really need is hospices that are truly run on Catholic principles. That's what's missing. And I bet people in the euthanasia movement, if we had more of those, they'd send their parents to ours.
Yeah, it is hard. Many hospice workers have very deep Catholic faiths. So and it helps a lot for you to identify yourself. As I'm Catholic and we are going to be praying together, and I know they're going to want to be, I'm going to be bringing in things for them to drink and so forth. And you can ask them, could you please, we would like to request that, we're visiting and we're worried that sedation may be a little too strong or whatever. You can have that conversation. And many hospice workers want to hear that and want to hear and want to provide the best care. So it's a hard thing, but I agree with you. It'd be great to have a Catholic hospice, but also but many hospice workers are very deeply Catholic. It's complicated, but it's messy.
That's really a conflict that I've had with what you just brought up about IV fluids hydration. I was working with somebody at a nursing home, and she had been through rounds of chemo and radiation, and was more or less coming near the end of her life, but not quite yet. And she really wasn't, maybe just having sips of water, but really couldn't swallow. So I asked the head nurse, and they knew me there, to give her IV fluids because she had me in control of all her health concerns. So in the meantime, I had contacted a lawyer because she said she wanted me to be the health power of attorney, and the lawyer said, you need paperwork, I'll make it out. So she probably had what they thought 2 to 3 days to live, and she wasn't drinking or eating. And I said I wanted to have IV fluids. I said I've read all about it, and I said that anyone that's dehydrated suffers a lot of pain. She said, show me the paperwork. And I said, he's making it out. She goes, unless you should put that paperwork in my face, she's not getting IV fluids. And I've noticed this to be a continuum, even in the hospitals where near someone's end of life. It always used to be, I remember my parents dying with IV fluids till they died. And what's going on?
Yeah, it's all about individual care. You don't want to use IV fluids. We don't IV fluids for, well, let's be clear, many patients die of fluid overload. They die of congestive heart failure. They die with, if your family member has edema, you press the tissue in, they're fluid overloaded. Their problem is not lack of fluid. Their problem is too much fluid. So, and that can be just as much as can be the case. So it's all about the individual care of the patient.
And then just to sort of like feel what you're saying, yeah, you're asked. It's sort of like the story my student said when the healthcare person said, "No, we're not giving him an insulin shot," and the family was like, "What?" But then they did finally. And what you're suffering actually because you experienced something like that, and you're asking us why wouldn't they do it, and how widespread is this? And that's a deep question. Dr. Flanigan's right. There's many healthcare workers at these places who are deeply Catholic, but just from what I've heard from a lot of people, I'm not a clinician, I think it is sadly pretty widespread. And it's a cultural change that's needed to understand the meaning of the idea that providing ordinary care is love and not providing it is a type of abandonment. And that idea is sadly dissipating. I don't want to make it sound too dark. There's great healthcare providers, but this is a reality, what you two are bringing up. And the question is, how can we restore that beautiful idea? And I think it's going to start first with Catholics getting back their idea of the Ars Moriendi, which we've all kind of lost. It's just kind of surprising to me when I first learned about all this. Gradually restoring it and seeing the beauty of it, and then letting it spread. I don't know.
Well, we're all so good when disaster strikes about bringing our lasagna and our meal organizations. I forget what they're called. What I'm trying to say?
Meals for Wheels.
No, not Meals for Wheels. When somebody needs, sorry, the meal train. We're so good at that. Well, the next step is really when someone is very ill to say, we want, not as medical professionals, but we want to just be there to help provide support when someone is very ill at the end of life, because you can't just sit there at somebody's bedside 24/7. You've got to sleep, you've got to eat, you've got to shop, you need rest, and people need to be spelled. Say, we want to really help, and it's going to take a group of us to do this, just the way we pull the groups together for meals. The other advantage of that is it can help take care of people at home. And the home setting is so rich for this. It's so rich for praying together. It's so rich for the priest coming for the anointing of the sick and the sacraments. The home is so good for being able to spoon in little bits of water or ask if they want to try a little sherbet. I love sherbet when you're near the end of life because it's cooling. As an infectious disease doctor, people always say, well, they're having a fever. We have to bring them to the hospital now because they need antibiotics. That's ordinary care. I say, whoa. I can give you very potent antibiotics at home. And well, they're not taking capsules. Not a problem. We have liquid antibiotics, which is what we give to all of our kids. We can give antibiotics at home. We can provide tremendous care and support at home. It just takes a lot of help. And unfortunately, the home care support is a whole nother calling to allow people to be home and provide. And frankly, if you're older, and what happens there is we all get a little, whether it's true Alzheimer's or it's just mild confusion and dementia of the elderly, which will happen to all of us when we're, most of us when we're really in our 90s. It is so difficult to go to the hospital. It's so hard. There's nothing better than having a 96-year-old receive care at home where they can watch their favorite TV show and they're just comfortable. They know where they are. It's good. And that requires a lot of TLC and care and support. And that's something our parish communities can do. And yes, you need a little help and support, but that's all possible.
All my life I've been hearing about how God has a plan for my life. Maybe He has a plan for my death.
Yeah, that's true.
And at what point do we interfere you know, whether on either side of the line. So you're a doctor and you're saying, well, you know, we have all this wonderful stuff that we do for folks, you know, when you're at that point. But maybe as a deacon, you know, you ask yourself, like when I'm dying, I mean, if whatever I happen to experience, maybe God wants me to experience that.
I went to see.
Maybe you're interfering.
Yeah, well, one of the monks at Portsmouth Abbey, Father Peter, had lung cancer that had caused a large pleural effusion and it spread. And one of the other folks there who had really knew him, was a great friend, said, can't you go see him? And you got to ask him to go up to Dana-Farber. He's got to get a second opinion. And maybe there's some trial or something that can be done. And I went to see him. I said, Father Peter, do you want to go up to Dana-Farber and get a second opinion? I said, Jim, I'm a monk at Portsmouth Abbey. You know, this is what I actually had been living my life for. He said he had received good medical care locally. And you know what? We live in an area where generally the medical care is very good. We're not in the middle of, you know, Sudan or somewhere. I mean, the general quality of medical care in this, you know, 100-mile radius is in general very, very good. I mean, the expertise is available. You don't have to always travel. But his opinion was, you know, it's okay, Tim. It's okay. I don't want to go seek a second opinion. And that's so important. And frequently, when these issues come up, you know, I'll tell Peter, you know, Peter, my mother's doing this. You got to do this. And you're like, oh, okay. Well, I know the best neurosurgeon. I'll call him up right away. The first step is not to call the neurosurgeon. The first step is he's got to go talk to my mother. Say, here, you've got this terrible situation. I'm so sorry. Yes. Are you okay with how things are going? Or do you want to go see this neurosurgeon? No, I definitely do not. You know, often our family members and our friends want things for us because it's hard for them and they want to help. First thing you have to do is go speak to the person. And being the healthcare proxy and all that is good, but it's only there if the person cannot answer for themselves. If you can answer for yourself, you're the one you have to go to. And people always say, you have to help this person. They've got this terrible condition. Oh, yes, I want to help. First step is, why don't I talk to them directly and see if they want me to help them? Maybe they don't want me to help them for whatever reason. So it's not up to us. But your point is very good.
Well, I remember my father had Alzheimer's, and when it got to the point where I think he knew where he was going or not going, I don't know, the way he expressed it was kind of convoluted, but I understood. It was like the song where, while all I ask you dying is to go naturally. You just want to, this is going to happen. I know, you know, I'm in this situation. So just let God take it where he wants.
Yeah. Mm-hmm.
Well, thank you everyone for coming tonight. Thank you both for answering all of our questions, and we're looking forward to next week. Wonderful. Thank you so much.